Thank you, Yvonne. I'm going to be speaking about the effects of racism on health, lessons from indigenous communities and post-apartheid South Africa. My name is Dr. Tony Mbewu, and I am a consultant physician and cardiologist currently working in the Isle of Wight. I am also a visiting fellow in cardiology in the Department of Medicine at a medical school within Sofako Makgatho Health Science University, South Africa, and I'm a member of the Race and Health Expert Group. And previously, I was the president of the South African Medical Research Council for 5 years and director of research there for 8 years. There'll be an introduction. We'll talk a little bit about racism and indigenous communities. We'll talk about how racism produces racial inequalities in health, discuss the mechanisms of that, and then briefly touch upon what can be done to curb and the effects of racism on health. We all know South Africa is the poster boy for racism in the world. Not surprisingly, therefore, 350 years of colonialism and apartheid had profound effects upon the health, lifespan, living conditions, income, education, and employment of black South Africans. What is less well known, however, is that racism in South Africa did not suddenly end with the demise of apartheid in 1994. And racism continues to affect the health of black South Africans. We will present research evidence on the effect of current racism and the effect of the legacy of apartheid on the health and lives of black South Africans. We discuss the mechanisms by which racism exerts its effects upon health, and we discuss means by which the effects of racism on health might be mitigated. Racism and indigenous communities. The Khoisan are the First Nation people of South Africa, an indigenous hunter-gatherer people who represent the oldest known lineage of modern humans. Racism impacted greatly on the health of the Khoisan. In the 300 years after the arrival and colonization by Dutch settlers in 1652 by Jan van Riebeeck, the Khoisan, who were at that time found all over southern Africa, judging by the presence of their cave paintings throughout the region, saw 90% of their population disappear through disease, displacement, and murder, to the point where today only 100,000 pure-blood Khoisan remain, many of them on so-called protected reserves, but there are also many Khoisan within the communities of the so-called colored people, particularly in the Western Cape. There is little data available on the health status of the 100,000 Khoisan in the reserves. I will therefore leave it to my fellow panelists to talk about the effect of racism on the health of indigenous peoples in their respective parts of the world. This is what Khoisan people look like. So if you want an idea of what Adam and Eve looked like 160,000 years ago, that's probably the best example. So I will be concentrating on the 93% of the 60 million people in post-apartheid South Africa who are non-white, who were oppressed under apartheid. 82% of them are African black, 9% are colored or mixed race, and they include many Khoisan people, and 2% of Indian descent. Racism produces racial inequalities in health. When in 1994 in South Africa, 350 years of colonialism and legislated racism under apartheid came to an end, and 331 racist apartheid laws were repealed, many expected the racial inequalities in socioeconomic status, education, income, employment, and health that apartheid had caused to gradually recede. Yet 28 years since 1994, striking inequalities in health status persist between different race groups, with colored, black, and Indian communities being particularly affected. For example, racial inequalities in infant mortality and under-5 mortality. Race disaggregate data, which is rare in South Africa, why I do not know, shows that in 1998, a black child in South Africa was still 5 times more likely to die at birth than a white child, through no fault of their own. This was still evident in the 2011 census data, 6 years after liberation, which showed that the infant mortality rate for blacks was 38.5 per 1,000 live births, compared to 20.3 per 1,000 live births for coloreds, 10.1 per 1,000 live births for Indians, and 8.3 for white babies. And this shows that data in graphical format for 1998. But even by 2011, that still persisted. There wasn't a census in 2021 because of the pandemic. The next census is actually this year. Secondly, life expectancy at birth. Life expectancy at birth for 2021 in South Africa was estimated at 59.3 years for males and 64.6 years for females. Life expectancy had reached a nadir in 2007 at the height of the HIV/AIDS epidemic, but has then increased by an astonishing 9 years, presumably largely because of the rollout of the antiretroviral program to about 7 million South Africans living with HIV and AIDS. Black South Africans, however, have been disproportionately affected by mortality from AIDS, which may partly explain the increase in the gap in life expectancy of white versus black South Africans from 8 years in 1985 to 15 years in 2004, which is shown graphically in this slide. The higher prevalence of HIV/AIDS amongst black South Africans could itself represent the indirect effects of racism on health, partly as a legacy of apartheid Bantu education, creating low levels of health literacy amongst black South Africans. And you'll find similar data for other health indicators, maternal mortality, etc., and also for mental health. Large racial inequalities exist in mental health experiences in South Africa. A lot of that work has been done by David Williams. How does racism impact on health? Mechanisms. How much of these racial inequalities in health reflect socioeconomic disparities, in themselves the result of legalized racism of apartheid, i.e. structural racism, and how much are the results of the persistence of racism in South Africa? And furthermore, by what mechanism does racism impact on health in South Africa today? Well, one of the mechanisms in terms of structural racism is income and health. If you look at a slide of burden of disease according to income, in data generated from South Africa's general household surveys, the table shows that in South Africa, where 60% of the population live in poverty on less than $2 a day, the majority of the disease burden for both communicable and non-communicable disease is borne by the poor, the only exception being for diabetes and influenza. And you can see from this chart, which I won't dwell on. Racial disparities in income. Furthermore, racial disparities in income have hardly shifted since liberation in 1994, nor in the last 100 years. Libra and Tatel have shown that in 1997, 1995, 1 year after liberation, and 2008, black South Africans had average income that was 30.2% of that of white South Africans in 1917, 26% of that of white South Africans in 1995, and 23.2% of that of white South Africans in 2008, indicating widening income inequality between black and white South Africans in the post-apartheid era. Furthermore, inequality within each of the South Africa's 4 major racial groups has also increased. However, largely due to government interventions, there have been continued improvements in non-monetary well-being, for example, access to piped water, electricity, and formal housing over the entire post-apartheid period up to 2008. So this slide shows the disparity in income in 2014 to 2015 between whites on the left and blacks on the far right. These changes occurred during a 20-year period from 1994 to 2015, when the South African economy doubled in size in real terms, accounting for inflation. The fruits of that economic growth, however, were not equally shared, with per capita income for black South Africans increasing by 93% in real terms from 1993 to 2008, whilst that for white South Africans increased 162% over the same period. However, these changes in personal income among black South Africans have had positive incomes for the health of South Africans, with increasing numbers being able to afford health insurance and therefore access to better health care, and the expansion of the primary health care system to poor South Africans. Also, to a certain extent, these huge inequalities in personal income were mitigated by the dramatic growth in government grants, now extended to over 20 million poor South Africans, a third of the population. Legacy effects of colonialism, apartheid, and post-apartheid capitalism. Legacy effects and socio-political impact of the Group Areas Act, repealed in 1991, which said blacks, colors, Indians, whites live in different areas, forced removals and ban to education, and about 300 other apartheid laws had profound effects on South Africa and continue to have legacy effects on South Africa to this day. We call it geospatial apartheid. Black South Africans overwhelmingly account for those living in informal settlements in urban areas, or shacks, and rural slums, with the absence of clean drinking water, sanitation, crowded and squalid living conditions, and inaccessibility of primary healthcare facilities, leading to high infant mortality, 5 times as we've seen, from diarrheal disease, pneumonia, and high adult mortality from TB and pneumonia. Violent crime and gender-based crime were and still are rife in these crowded and impoverished communities, with staggeringly high levels of youth unemployment, up to 80%. And of course, poorer communities in South Africa were disproportionately impacted during the lockdowns and economic downturns, a fall of 7% of GDP in 2020, of the COVID-19 pandemic. This geospatial apartheid determines access to quality education, income and employment opportunities, housing quality, neighborhood amenities, as well as exposure to stressful experiences linked to the social and physical environment, a form of structural racism. These proximal determinants in turn impact upon the health of those living and working in those post-apartheid enclaves, an indirect enduring effect of racism on health in South Africa. But it also affects non-communicable disease. Our work has shown that apartheid geography impacts upon not only infectious diseases such as TB, pneumonia, and gastroenteritis, but also non-communicable diseases such as hypertension, with black South Africans in urban areas having significantly higher prevalence of hypertension than those in rural areas. This could relate to a multitude of causalities, such as different diets in urban areas, but it could also relate to greater psychosocial stress for black people in urban areas, including real and perceived racist microaggressions. The experience of microaggressions in childhood, furthermore, such as in apartheid South Africa 40 years ago, can impact upon the incidence of NCGs such as hypertension in later life in post-apartheid South Africa. Mechanisms of effect of racism on health other than socioeconomic factors. The narrowing of inequalities between different race groups in educational status and household income, though modest, has led some to conclude that since race is a social construct, rather than a biological one, persisting health inequalities are simply due to persistent inequalities in socioeconomic status. In other words, racial health inequalities are simply a proxy for socioeconomic inequalities. However, research has documented that racial disparities persist in post-apartheid South Africa even after socioeconomic indicators are accounted for. For example, overall infant mortality rates showed little change from 1998 from 1998 compared to 1987, but the infant mortality rate for blacks, which was 6 times higher than for whites in 1998, remained 3 to 4 times higher when income, education, and living conditions were adjusted for. The mechanisms of effect on racism on health other than socioeconomic factors continued. Williams et al., using nationally represented data for South Africa, found that black South Africans have higher levels of psychological distress than white South Africans, even after adjustment for income, education, household wealth, and multiple stressful life experiences. Blacks, colors, and Indians were 2 to 4 times more likely than whites to report acute and chronic experiences of racial discrimination and had high levels of psychological distress than whites. Adjusting for income and education reduced the association between race and psychological distress by 32% for blacks and 43% for colors, but the association remained significant. And the coefficients of race and education were further reduced by 25% when discrimination was added to the model, suggesting that discrimination makes an incremental contribution in accounting for the residual effect of race after income and education are controlled. Importantly, even after further adjustment for a global measure of stressful life experiences and psychological resources, such as self-esteem and mastery, discrimination was still adversely related to psychological distress. Lastly, what can be done to curb and reverse effects of racism on health? I will touch briefly on this. Firstly, research and public health activism. Recognize and measure the problems. And the recent Black Lives Matter movement around the world has illustrated this, and of course Black Health Matters too. Address issues of systemic racism, recognize them, and structural racism. Secondly, recognize how these operate. through socio-behavioral mechanisms and also through biological mechanisms such as weathering, etc. Set up bodies to do these tasks, such as this Race and Health Observatory. Research disseminates and implements solutions through universities, through conferences such as this, work of nonprofits, the introduction of diversity, equality, and inclusion programs in corporates, institutions, and universities. Conclusion. Racism in South Africa, extending through 370 years of colonialism and apartheid to the present post-apartheid era, has had and continues to have significant effects on the health of Black and Indigenous communities in South Africa. A growing body of research indicates that self-reports of racial or ethnic discrimination are inversely related to physical and mental health. Some of these effects operate at the individual and community level through the daily racist microaggressions that Black South Africans face in their daily lives, impacting upon their physical and mental health. Some effects of racism on health operate through structural racism, often the legacy effects of apartheid, such as geospatial apartheid, in which different ethnic communities continue to live in largely segregated cantonments, with Black people often living in squalid informal settlements, in townships on the peripheries of towns and cities, set far apart from their places of work, and in rural slums. Perhaps the largest effect of racism on health is through the huge inequalities in household income that persist between different races as a legacy of apartheid and as a result of racism today in employment practices. David Williams notes, in order to understand and effectively address the striking racial inequalities in socioeconomic status and health status in South Africa, researchers and policymakers should give greater attention to the upstream mechanisms by which racism in larger society has adverse effects on health. The cause for these persistent disparities, to a large degree, lie in the mechanisms by which these health disparities arose, a product of the vast socioeconomic inequalities that apartheid produced between race groups. The political liberation achieved in 1994 has not been followed by economic liberation, leading to hopelessness, anger, and social unrest, particularly among young Black South Africans. Racism in South Africa, both current and historical, continues to impact upon the health of Black South Africans through adverse effects on employment rates, educational attainment, household income, housing conditions, exposure to violence, and including gender-based violence, and access to health care. Thank you. I'm now going to ask the panelists for the session to join me on the stage. Does this one work? Yeah. So let me introduce these panelists. Some of you have met them already. Starting at the far end is Janet Smylie from Canada. I'll allow her to introduce herself in a minute. Irma Velasquez from Guatemala, who we are so relieved to see, who's healthy, sitting beside me now. And Roxanne Jones from Australia, who's already spoken a bit, but will speak some more. They are going to address the effects of racism on health in Indigenous communities. We look forward for the next 15 minutes or so to hear their inputs. So firstly, can you just briefly introduce yourself with your name, which institution you work for, where you come from?
Is this one working? Yeah. Tanzi Atawia, Kakio Kitan Skatinawo, Janet Smylie Nitsi Kasen, Ochinia, Saskatoonina, Whitford Lake, Red River, Nikan, Takaranto. My name is Janet Smylie. I greeted you all in Cree. It's a developing Cree. And I'm a professor of public health and family medicine at the University of Toronto in a research chair at a hospital network called Unity Health Toronto.
Hi everyone, my name's Roxanne Jones. I'm a proud Aboriginal woman from Australia. My family have cultural connections to the Palawa people of Lutruwita, Tasmania. I am a PhD candidate and research associate at the Australian National University.
Sakariknan, Sakariktat, Sakarit Siguantinimit. My name is Irma Velasquez Nimatuj. I am a Maya Quiche woman from Guatemala, from the highlands of Guatemala. I am a social anthropologist and journalist also, and I'm working as a university professor in South Mexico and in Guatemala.
Thank you very much. Irma, since we haven't heard from you yet, perhaps we should start with you. What I'd like you to talk on is your input on the effects of racism on health in indigenous communities in Guatemala.
Thank you, Dr. Tony. Well, the impact of the racism in the health of indigenous people in Guatemala is huge. And in order to understand the impact of the effects, we need to understand the history of Guatemala. The Guatemala has a very long history of dispossession. The dispossession is huge, and it starts when the Spanish came to Guatemala and tried to take almost everything from the indigenous people. The colonization, like South Africa, was during 300 years, but the effects continue until today. So we have almost more than 500 years of the effects of the colonizations. So now what is the situation of indigenous people in Guatemala in terms of the health access? This is terrible. For example, we are not a minority in Guatemala, we are the majority, because Guatemala has around 17 million people, and we are almost the 50 or the 60% of the total of the population. And in some places, you find like the 100% of the population is indigenous. For example, in the north of the country, or in the area that I came from, or in some parts, the majority of the people is only indigenous people. But in terms of the access, we don't need a minority access of the health, because we are not a minority, but we receive like a minority access of the health from the government. And the data is terrible. For example, half of the children in my country confront malnutrition, desnutrition. So also we don't have a data about the situation of the indigenous women. We don't have it. There is nothing about what is the situation in terms of the malnutrition or desnutrition from the indigenous women. There is no budget. There is no, how do you say, research. There is no research about this situation in my country. And so the extreme poverty is 3 times higher among the indigenous population than among the non-indigenous population. So the situation is difficult. We live in the middle of the social confrontation, because the resources is in the hand of the white elite, and the white elite control almost all the country, like if the country is their finca, you know. So this is a very complex situation.
And Irma, in my country, South Africa, race aggregated data on health indicators is really only collected every 10 years at the time of census. Do they collect race aggregated data on health indicators in Guatemala?
Well, race as a social construction, but race as a oppression, as a system of oppression and historical oppression, that is not accepted in my country. You know, the race is only for the academia, it's only for the activism, it's only for the indigenous people, but not for the government. The government never accepts that we are living in the middle of the of the racist country. So this is a very problematic because we don't have any data about in relationship with the race and health. But also we don't need it, you know, because it's evident when see all the data. For example, in Guatemala, we only have 7 general hospitals, only 7 for 17 million people. So could you imagine this situation? This is terrible. So, and in each hospital, you only find 2,000 beds for the population. So I came from a very rich country in terms of the natural resources, but also I came from the one of the most unequally country in terms of the distribution of the health. So the problem is not the health. The problem is how the health is concentrated in a country like Guatemala, where the majority of the population is indigenous. But we don't have the political power. So one of the work in my country is to take the political power in order to change all this inequality situation in health, in education, in other social services. If we continue with the same pattern of the control of the power, it's impossible to change the state, because the race is connect with the state. The race is part of the state. So in order to change this, we need to move the state, you know? But this is easy to say, but it's difficult to do.
So I allowed Irma to speak a little because we hadn't heard very much from Central America and South America. But Roxanne, you spoke a little yesterday. Could you tell us a little bit more about the effects of racism on the health of indigenous peoples in Australia?
Yeah, thank you. So in Australia, going back to sort of pulling on that data question, I have the privilege of working on a national project called MyQI, and MyQI is a study of Aboriginal and Torres Strait Islander wellbeing, and it's a national study that is Aboriginal controlled and Aboriginal governed. So it's a really unique study, and we've been able to gain data from over 12,000 Aboriginal people. So through that study, one of the major themes that we work on is looking at the experiences of racism and in everyday life and also in healthcare settings. So we've found that one of the major protective factors against racism, and this isn't to say that the onus lies on Indigenous people to correct the experiences of racism, but this is important when we are talking about health and improving health and well-being. We've found that culture and connection to culture and cultural practices are a really strong protective factor against those experiences of racism. So for us, connection to culture is connection to country, visiting country, speaking with elders and learning their cultural knowledges and practices, participating in art and dance and all of those sorts of things. So, and importantly, those trends seem to be equally as important in children as well. So, yeah, we've been able to sort of, with this really unique data set that has been developed through extensive community consultation. It's a really meaningful data set, and it's exciting to be able to work on a study such as that.
So as I mentioned, in my country, the Khoisan people, only 100,000 pure-blood Khoisan remain. In over 300 years, 90% of the population disappeared, largely through disease. I thought the same thing happened in Tasmania, that there were hardly any indigenous people left in Tasmania. And how is their health status at the moment?
Yeah, so great question, and relevant to my family. So yes, Australia was hit incredibly hard by colonisation. Our Aboriginal people suffered genocide and were stolen from children were stolen from their families routinely for decades. My family, I'm a descendant of the stolen generations, and really a product, I suppose, of the White Australia policy in many respects. So yes, Tasmania was, Lutruwita, Tasmania was hit incredibly hard by genocide. There was this prevailing understanding or myth, really, that our people became extinct from the genocide. But we are strong. There is communities down there that are thriving, and I suppose my experiences of racism as a light-skinned Aboriginal woman are different. But I suppose those different experiences still have an impact. And so there isn't. Communities, I suppose, look a little bit different, I would say, as a result of colonisation, as a result of White Australia policy. But that connection to culture remains strong, and really proud people.
So like we have in South Africa, where there's so much racial admixture, you have colorism in Tasmania, do you?
Yes, there's varying degrees, I suppose, yeah.
Okay, Janet, can you just tell us briefly a little bit again about the effects of racism on health amongst the Indigenous peoples of Canada?
Sure, and I'm going to ask for that slide about epistemic racism to go back up. Great. So thank you. And yeah, we're supposed to be talking about lessons learned too. And so one of the lessons that we've been learning is what's counted counts, right? One of the lessons that's clear, right, is global economies impact health and well-being. One of the lessons that's clear is that Indigenous peoples, right, and African peoples do better when they govern their own affairs. From my context in Canada, which is a relatively affluent global country, because racism operates at so many levels, one of the strategies is to make Indigenous people disappear. So I'm a Métis person. Another strategy actually is to make up a narrative that there's none of us left, right? Or make up a narrative that you're only Indigenous if you're full blood, whatever that means. So I wear this sash, and it actually is over 100 years old. It was loomed here in England. It was a trade object. But our Indigenous mothers put these sashes on their children, traditionally worn by Métis men, because we're Indigenous forever, right? Because that's cultural continuity, and we're matrilineal. So that's part of our narrative. And many of the narratives that Indigenous people have disappeared, or there's no Indigenous people, are false narratives. The city of Toronto, where I live, there's 88,000 First Nations, Inuit, and Métis people, yet they're largely ignored in our public policy. The place where I work, there's probably more specialist physicians in hospitals than, it's probably in the top 10 in the global world. Yet there's 17,000 First Nations, Inuit, and Métis people that have nowhere to go. So, we also, 90% of this population is living under the low income cutoff. Living conditions are probably better than the slums in South Africa or in Guatemala, right? But still the inequity is striking. I think it's appropriate to talk about epistemic racism right here in London because it came from here, right? So the idea that one set of ideas and ways of doing things, one health service is better than another, right? And that was part of the civilizing mission, right? there's so much strength in Guatemala, majority indigenous people, like indigenous languages, like our indigenous midwives go there to learn traditional birthing practices, right? And there's resilience as well. So we're supposed to be plain language. Epistemology is just a fancy word for ways of knowing things. I think maybe David Williams refers to it a bit as cultural racism. But the reason why I think it's so important for the Race and Health Observatory is I think that you're going to benefit by using new models. And I think there's still a big resistance. So we can make up data arguments. I have good data. I try to work and publish in prestigious journals. But sometimes I say my day job is just like making arguments that the community already knows. We heard from Irma, community already knows these things, right? But I have to like put it in terms that the dominating knowledge system will believe, right? Because they don't believe community, which is unfortunate. If I could, I think I can just click to the next slide here. So I talked yesterday about an indigenous model, right, of the Toronto Birth Center. Part of it is then, if we're going to do these by community, for community models, we need to do them not only because it's immoral to like decide that one way of thinking, one Eurocentric, positivist, scientific way of thinking is better to solve all the world's problems. It's also against international law, because we have a UN Declaration of the Rights of Indigenous People that says that actually Indigenous peoples have the rights to determine their own affairs, and that includes our health and social and education affairs. But it's also way more effective, and I think that this is relevant to address gaps and ethnic disparities like in health access and health services right here in the UK. And I think this epistemic racism is really still strong here in the UK, and I think we should be talking about it. And yes, it's very good to develop evaluations of these systems because then we can be thoughtful. And I've trained most of my career in biomedicine and epidemiology and social science, so I believe our communities need to have rigorous evaluations. But just to know, sometimes these evaluations actually are labor intensive and get in the way of things that are obviously working. The other example I just want to leave you with is what we did around COVID and vaccine hesitancy. We talked about the problems of trust. One of the things that is very strong in many racialized and indigenous communities is our social networks and our kinship. So we used our social networks and our trust relationships within community to build a comprehensive COVID response program. But I'm imagining many of you that do this kind of work in socially excluded communities encounter resistance at every level. So for example, we already knew from Ebola in West Africa that you could train community people to do case management. So we said we're going to train our own people to do case managers because we don't trust people coming to our communities. I talked about the way that our children are still taken at birth very commonly. And basically, the public health people were saying, oh no, you can't train community people, you have to be a qualified health professional. And we're like, no you don't. And we made our training. I had an indigenous postdoc and the midwives. Public health went and they said, oh, it's better than our training, right? And we're doing it right now. So, but it's that kind of standard, which in a way it's like, okay, well it can't be as good because it was developed by indigenous communities. So I just wanted to add that that's a lesson that I think is going to be very important in advancing equity here in the UK. Thank you.
Thank you, Janet. Thank you, Irma. Thank you, Janet, Irma, and Roxanne. We have about 15 minutes left in order to take questions from the people in the room and also questions from people phoning in online. David.
I don't have a mic, I'm not sure I need it, but could you mention or explain to us when you say that Indigenous children in Canada are stolen at birth? Could you explain the process? What really happens?
So up until recently, so the first thing to know, because we've heard about residential schools, most people, and then most people globally now have heard about the unmarked grave. So it was actually partnership between churches and the federal government. There was a civilizing mission, which actually was based on epistemic racism. So the idea that actually it would be helpful to Indigenous people to stop us speaking our languages. The reason why I have developing Cree now, because my grandmother thought it wouldn't be a negative thing to teach Cree to her daughters. And basically, but now there's more First Nations, Inuit, and Métis children that are in the care of child services than there was at the height of residential school. So very commonly, and in my practice as a family doc for the last 28 years, Indigenous women are inappropriately identified as being mothers at risk. It still happens with the midwives all the time. There was something called a birth alert in Ontario where there would be a secret flag put on the chart, and then automatically the child would just be apprehended. So instead of kind of responding like in a pro-social way, understanding that perhaps if there's a pregnant person at risk, maybe they just need some supports, which is what the whole Birth on Country movement is about, or some of the other work that we've been doing in birthing. A woman is isolated, people from outside community make judgments about their ability to care for the child, and then if the birth is happening in a hospital, the child is just removed from the care of the family.
Any questions online? Oh, I'm sorry, in the middle there.
Brent McInerney, I just volunteer in my local community and a member of the Race and Health Observatory stakeholder engagement group, and I really can connect with that bit about actually the trust in the community. And I just want to give you a local example. I know we've given some real national examples, but for me it's like when I walk the street, what does it really matter to the people really in terms of what I do or what I say really. And I organised a coach for a number of the school children in an area of greater need. They're not deprived, they're not undeserved, you know, that's labelled them, but there is greater need there really. And because we've worked with the families, and I had really for a number of years, a number of the Roma children that their history was when they got on that bus and the family's bus, they weren't coming back. They weren't coming back. So this boils down to even social events as well, really, I suppose, long term. And they were really clear a couple of years back, really, that their experience from the countries they come from was the fact that actually when those children got on the bus, they weren't going back to the families at all, really. So that's kind of like a really micro level, ward level bit. But I think my point is how much importance do you feel, and it's quite a weighted question, on that actually trust that we must gain and keep, but we can also lose.
Good. Time for one last question from Yvonne.
Thank you to all of you for sharing your stories with us. I've been working in race equality for some time now, and I don't think I've ever heard anything so distressing as I've heard from all four of you. And my question is to Irma, and it's wonderful to see you here today. It really is. You said that there were 7. Am I going to get this right? 7 acute hospitals for 70 million population. And each of those hospitals had 2,000 beds. And I'm just trying to get my head around, because this is London with a population of about 12 million, maybe just a bit less. And there have to be at least 25 hospitals, big hospitals, in this area. How does that work for people when they become sick? I can't get my head around how it works in terms of healthcare for the population in your country.
Okay. Yeah, this is incredible, you know, but this is Latin America. And the situation in Guatemala is almost the same. In El Salvador, for example, or many years ago in Bolivia, it was another example, you know. So this is true. This is incredible. What the people do? Well, the people sometimes die outside the hospital. The people need to wait 2 to 3, 4, 5, or 1 week in order to be attended for a doctor. So if you need a surgery, a huge surgery, you need to wait sometimes 6 months, you know. So the people die in my country. This is a huge problem. But there is another data. The chronic malnutrition inside the children, there is 8 of every 10. The malnutrition is in 8 children of 8. Oh, of 10, I'm sorry. 8 out of 10. Could you imagine this? So the children in my country, they don't have hope. For the reason, the majority try to escape of Guatemala and try to go to United States. So part of the migration problem is this inequality in health. But in education, it's almost the same. There is no access. So health is very important. It's a social service. But when you see the budget, the national budget, you understand why the people live in those conditions. You know, there is no public health service in good condition in my country. This is in the city. We have 7 hospitals in the cities. But if you go to the countryside, there is no hospitals there, no hospitals. You can find a very small clinics, and there is the building is there, very small buildings. But if you go inside those clinics, sometimes you don't find doctors. There is impossible. You don't find any medicine, you know. So it's a huge problem in Guatemala. And in other parts, South Mexico is almost the same situation.
Okay, I've been told that we're going to move on now to one of our lived experience videos, presumably on the effects of racism on health, lessons from indigenous communities. It's a 10-minute video. Before we do that, I'd just like to wrap up. If anybody else in the room or online has questions, then they can address them to the panel members of the coffee break or online. I'd like to thank Janet, Irma, and Roxanne for their amazing inputs on the experience on the effects of racism on the health of indigenous communities in Canada, Guatemala, Australia, and of course in South Africa over the past 350 years, and the continuing effects of racism on the health of those indigenous communities. And it reminds us that the work of the Race and Health Observatory is clearly focused on the NHS, but it's part of a global solidarity movement in terms of addressing the effects of racism on health. So we're going to have a video now, the lived experience video relevant to the theme. Thank you again.
Hi, and thank you for having me today. Before I begin, I acknowledge the Awabakal peoples as the custodians of the unceded lands on which I am presenting from, and pay my respects to their elders past and present. My name is Christy Crooks. I'm a Yarra woman. I'm also the Public Health Aboriginal Team Lead, and I'm undertaking a PhD in Pandemic Planning and Responses. And I acknowledge my colleagues Carly Taylor, Katie Brett, and Charlie Law for their friendship, strength, resilience, and leadership. I will provide some background to the work we have been doing in the COVID response within a local public health unit in New South Wales, Australia, and describe how we embedded cultural governance within an emergency management system. Hunter New England Local Health District covers a large geographical area, providing a range of public health services to approximately 940,000 people, including approximately 65,000 Aboriginal and Torres Strait Islander people. Aboriginal peoples are disproportionately represented across all health indicators than any other population group in Australia. But the epidemiology only shows the numbers and disparities and doesn't really reflect what's going on for families and communities. Health is often written from a deficit perspective, highlighting the gaps and issues, and makes it more attractive to fund programs. However, there is so much more to celebrate, and the strength of our peoples are in connection to our culture, country, family, and community, and it's these protective factors that aren't usually considered when developing or implementing programs or research. Everything we do comes from a social justice lens because all of the injustices we have had endured and continue to face. But we can't address health without considering the social and cultural determinants of health and ignoring the ongoing impacts of colonisation that has led to a history of oppression sustained by systemic and institutional racism. Our communities need both equitable access and opportunity to thrive. We need justice. We need to get rid of those barriers. And to do this, we need to demand space and voices at every table where decisions have been made for us in the past. And we need cultural governance in place to ensure this happens. We as Aboriginal people often view our health in holistic terms, encompassing spiritual, cultural, social, mental and physical aspects of well-being. Health and well-being in our community is not just about the absence of disease. These cultural domains are the drivers of our work in tackling key issues of voice, representation, empowerment and self-determination of Aboriginal peoples. Our Public Health Unit and friends did some work with Aboriginal communities about their experiences of the 2009 H1N1 pandemic. Communities told us what culturally appropriate pandemic responses should look like. And at the centre of all that we did, we were told that governance through respectful and meaningful partnerships with Aboriginal peoples was most important. Historically, Aboriginal people have fared worse outcomes than any other population group in past pandemics, even though we only account for 3% of the country's population. We were excluded from pre-2009 plans, which meant pandemic plans and responses didn't reflect our ways of living and being. This led to 2009 pandemic having an inequitable impact on Aboriginal peoples, so this time we had to make sure that our response was different. When COVID started, Hunter New England Health adopted a standard incident command system. It's very military-like in its structure that reorganises public health staff into teams and respond to the pandemic. But unlike other areas, we have another arm in our ICS, the Public Health Aboriginal team that provides cultural governance across the entire system. At first, we wanted to provide cultural oversight over teams, but providing oversight wasn't enough. We needed our own team to drive our own local responses, but at the same level as all the other teams in the emergency management system. We formed the team in February 2020 and created many different positions within our team to oversee the local response of Aboriginal communities in our area. We also ensured that we had an Aboriginal Wellbeing Officer. COVID has heightened its systemic racism, and it's been a very challenging and distressing time for us. So it was important to have some space to be able to connect culturally and stay grounded together. We wanted to provide every person in Hunter, New England, an opportunity for culturally appropriate care if they got COVID. But to do this, we had to know which of our cases were Aboriginal. We implemented an accountability framework into every pillar of the response. All the white boxes you see here are the actions taken by every team to ensure that they are asking the case if they are identified as Aboriginal or Torres Strait Islander. These structures were fully informed and led by the Public Health Aboriginal team in our data governance structure. We embedded governance in COVID case and contact management and established an Aboriginal cultural support model. Our experiences within the health system and welfare organisations had led to mistrust, and our communities not feeling safe to disclose crucial information to keep themselves and their families safe. Our team offered follow-up support to cases and contacts and their families to identify any barriers or extra supports they needed to safely isolate, such as personal and household items, foods and medications. In March 2020, we formed a district Aboriginal governance group on COVID, which consists of all of the 8 Aboriginal community-controlled health services in our area, and representation from the Aboriginal Health Unit and Child and Family Health Unit as well, to name a few. So this group still meets every fortnight, which highlights the strength and trust of those relationships that we have built. Through our advocacy, we also activated the District Aboriginal Vaccination Steering Committee and established a data governance group as well. Too often, whole of population health services work within a top-down approach where the Western system determines care for Aboriginal peoples and communities, without Aboriginal peoples being included to freely identify issues and identify solutions. We prefer a bottom-up approach, which can encourage active participation and shared decision-making based on shared learning, shared power, and mutual accountability and commitment. So my PhD is to explore deeper understanding of real engagement and governance with Aboriginal peoples in infectious disease emergencies. We employed an Aboriginal-led Indigenous research and community-based participatory action research approach, which is a decolonising methodology that challenges the Western knowledge paradigm. We indigenised the citizen juries model to incorporate Aboriginal values, principles and practices into the engagement model. In late 2019, we did some work with Aboriginal communities to see if the community panels is a good way of engaging Aboriginal people in making decisions about public health emergencies. This was before COVID, so we had to use a hypothetical pandemic influenza to work through the idea and to see if the process works. However, in early 2020, we were asked to do some additional work on COVID, and we ended up with a really culturally informed way of engaging Aboriginal peoples using traditional approaches of collective decision-making and yarning as key elements to understand local issues. In honouring what communities told us back in 2009, we ensured that local communications were developed and disseminated by Aboriginal people. The messages our team constructed make sense for our people and shared in plain, easy to understand and culturally appropriate language that could be shared far and wide. Reviewing local, state and national documents, we have found quite a lot of issues in the way that Aboriginal people have been placed within this landscape. We always do a keyword search of Aboriginal. The first time Aboriginal people are mentioned in this document that you can see is within the cases who are non-compliant. Aboriginal community section is hidden within the context because it was placed within item 6, correctional facilities. In other key state documents, Aboriginal peoples come under police-managed hotels, and following a logical flow of categories in a triage section tab, prison and detention is positioned after communities. This is a common issue noticed by our team, locally and at a state level. Too often local and state health departments have made decisions around moving to business as usual to shift focus from supporting individuals to supporting communities. These decisions were made for us, without us. But there's still a long way to go. Racism continues to exist within the health system. One-off consultations don't work. Ongoing community engagement that benefits community is better. One Aboriginal person on a committee or reference group is not engagement, it's tokenistic. Aboriginal peoples are considered a priority, but there needs to be real action and changes to current governance practices where we are at the table voicing our ideas and solutions and actively participating in real decision making. We know the issues that impact on us and our ways of knowing and being, and we should be at the table guiding the development of health policy and practice at all times and at all levels. Through our continued advocacy and fight for inclusion, to break down the systems and processes in place to marginalise us, we have demonstrated that when there are good governance processes in place, the outcomes look after themselves. I couldn't have done this work without a team of people, and I thankfully acknowledge Aboriginal and Torres Strait Islander people past and present who have paved the way to enable the work that our team has done and can do in this space. Thank you.